My name is Lynn Lowe, and the three of us up here are from Nova Scotia, and we're all very friendly and welcoming. And so we are a small group here this afternoon, and we really appreciate you being here. But if people are interested to move up to the front, we're not that scary, but feel free to stay kind of further back if you want to as well. So I am technically, I guess, a senior policy analyst with the Mental Health and Addictions Program in Nova Scotia. And we've been working on a number of projects to improve services for people who use drugs, including alcohol. And today we're here to talk about one of those new initiatives, and that's the launching of an inpatient addiction medicine consult service at our tertiary care hospital in Halifax. I'm not going to be doing the main presenting. We have Heather Lonas, who is the health services manager of the new team, and Dr. Katie Lines, who is a addiction medicine psychiatrist who helps support the team. And they're going to do the main presenting, but I'll be kind of here at the end to kind of facilitate some discussions and really hope you are interested in the topic, and we hope to learn some things from you at the end. So thanks very much.
Good afternoon, everyone, and thank you for participating in our presentation on the inpatient addiction consult service in Nova Scotia at the Halifax Infirmary. I am the health services manager for 3 different services with Nova Scotia Health, and the inpatient addiction medicine consult service is one. I also manage the inpatient withdrawal management unit and the outpatient opioid recovery program. I've been a health services manager for just over 2 years, but I've worked in mental health and addictions in different capacities since 2012 as a registered nurse. 8 of those years I spent working in the opioid recovery program, and that is where I first saw the need for an inpatient addiction medicine consult service, as we received regular calls and inquiries from surgeons, emergency departments, and inpatient teams, looking just for some guidance and some suggestions on how to manage patients' pain post-op, or how to manage patients who presented to the emergency department in withdrawal. Just one second here. And none of us have any disclosures. So this project was partly possible with support from Health Canada's Substance Use and Addictions Program. The views expressed herein do not necessarily represent the views of Health Canada. And this is our beautiful Halifax. This is Citadel Hill, looking down on Halifax Harbour in the downtown core. And this is the entrance into the Halifax Infirmary. So the outline today, we're going to have a look at the service development, how the inpatient addiction medicine consult service came to be. We're going to look at service accomplishments and findings, and then we'll have a little breakout discussion and leave the floor open for any questions that you may have. So before the inpatient addiction medicine consult service was official, we had an informal service. We're a team of very compassionate addictions medicine clinicians, physicians. They would respond to emergency departments and inpatient physicians who were looking for advice on treatment recommendations for clients who had substance use disorders. We received funding for the inpatient addiction medicine consult service in 2021, 2022, and completed a jurisdictional scan, including medical advisors and advisory council team in 2023. So what does the service look like? So the service is at the Halifax Infirmary, and it operates from Monday to Friday, 8 a.m. until 5 p.m. The service sees patients on the inpatient units and the emergency department units. And there is a Monday to Friday rotation of 6 physicians who rotate 1 week at a time. The service, as it stands right now, it has 1 RN and 1 social worker. And we do have a peer support worker, so we partner with Peer Support Nova Scotia, and we felt it was very important for patients who are experiencing substance use disorders to be able to connect with somebody who truly understands what it is that they're going through. And we have weekly case reviews on Friday afternoons, and we also have kind of process meetings on Mondays. And that would be our team meetings. We get together and decide, talk about what's working, what isn't working, and look at ways to improve how the service operates. So this is a snapshot of clients seen by the week by the Inpatient Addiction Medicine Consult Service team. There have been 300 new consults, 265 unique patients, and 1,464 patient encounters. So the consults don't end at just seeing the patient one time when they go to see a patient in the inpatient unit or the emergency department. The patient is followed throughout their inpatient stay by the Inpatient Addiction Medicine Consult Service. There is also an addiction medicine consult service that is not inpatient, but it's a phone number that is used provincially for pharmacists, physicians, nurse practitioners to connect with addiction specialists to get recommendations over the phone on how to manage clients who are presenting with substance use disorders. And the service has received over 320 calls over 1 year reporting period. A large part of the inpatient addiction medicine consult service is to provide education, of course, to inpatient teams and emergency departments to build capacity amongst those teams, to build comfort. So far, there have been 9 sessions for acute care and emergency department nurses, and there have been greater than 150 participants who attended these educational sessions. And there's ongoing evaluation of the new service, as expected, using a logic model and administrative data collection, patient and provider feedback. So we do have surveys that we encourage patients and providers to complete to help guide our way forward. And an advisory council survey. Our advisory council, there are people with lived and living experience who make up the advisory council, and of course their input is imperative to building and sustaining a successful inpatient inpatient addiction medicine consult service. And we are planning focus groups and interviews in the future, just to guide our way forward. And lessons learned. As I'm sure you can imagine, any new service, there are ups and downs. There's always room for improvement. I don't know if Katie, you wanted to speak to some of, Katie's on the front line, so she's able to kind of speak more to some of the challenges that she's faced so far. I'll get this to you.
Thank you, Heather. So I'm Katie. I'm an addiction psychiatrist in Nova Scotia, of which there are very few of us. But to take you back to the beginning of this inpatient addiction medicine consult service, like Heather said, at first it was informal, and it really was our outpatient providers that are inpatient docs would either know personally, or they would know the patient was connected to an ORP or an OAT treatment hub, and they would reach out to them and say, what do I do with their Suboxone? Do I stop it? What do I do about their acute pain? And during that time, some very committed residents and faculty felt maybe we can leverage some of this knowledge and provide some informal support. So it really was through word of mouth, through some very significant staff and resident champions that allowed for some ongoing following of patients, new consults, but it really was piecemeal, haphazard, and certainly not formal. So really a proud moment to be able to say now there's a formal service. It's got a brick and mortar office. We have safer supplies. We have all of these things and resources. And it's just such a pleasure to be a part of. But this is partially why the planning and evaluation was so important. We knew there was a significant need and that we had to do this in a systematic way so that it was sustainable going forward. I'm going to take you through some of our initial data, which hopefully just high level paints a little bit of a picture of the last year. So the people who, or clinicians who participated in our educational sessions, we asked them, what kind of contact do you have with people who use drugs in your clinical work day to day? And what's your confidence in actually interacting with and treating or helping these people? And so as you can see, it was quite a broad range of people that were providing clinicians were providing the educational sessions to. Some had rarely see patients and people who use drugs, all the way up to daily. So people who were very active in this space with a large variety of confidence. Of course, some of the lower confidence was amongst clinicians who rarely saw or helped this population, and there was more confidence amongst educational session participants that saw these patients more regularly, which of course makes sense, but it's nice to know who you're talking to and what their level of comfort was to begin with. So we asked this population for feedback on our educational sessions, which, as Heather said, were a huge component of service delivery from our consult service. So most of the people said they plan to apply the knowledge that they learned during our educational sessions on treatment planning, knowledge on reducing stigma, describing what a substance use disorder even is, and then in other areas that we were providing education on. So this gives a little bit of a lay of the land of the types of services that are consulting us and asking for support. So these are not all the units that consult us, but these are the top 6 units. You can see general medicine, which no surprise there, along with our emergency colleagues, some very common surgical colleagues, and our hospitalist service. So that's where most of our consults are coming from. Most of those consults are for these different substance use disorders, and as you can see, general medicine has more consults for alcohol use disorder than neurosurgery. Does that mean that There are less patients on neurosurgery with alcohol use disorders, maybe or maybe not, but these were the types of referrals that we were getting. You can see quite a few for opioid use disorder, alcohol use disorder, and some for stimulants, less so some of the other categories. So by a primary substance use disorder, these are the different actual reasons we were consulted. As you can see here, it's mostly for pharmacological management of the person's underlying substance use disorder or multiple substance use disorders. Sometimes the consult was actually for harm reduction or rarely diagnostic clarification, but there's certainly a significant component for system navigation as well. So we're really happy to try to help our colleagues in these areas. This is very preliminary data. As you can see, low numbers, however, I think very important trends that we'll continue to look into over the next years, hopefully, of this service. So as you can see here, since the starting of this service, there are more patients discharged with support and referral to appropriate areas of care outside the hospital. There are more patients, less patients leaving against medical advice, and we were involved with more patients being transferred to different facilities. So as with other provinces in Canada, we suffer from being quite spread out. And so many of our patients would actually get transferred to different facilities with different levels of comfort around managing substance use disorders. So we would do our best to connect with them, have them use the phone consult service, and provide very clear kind of instructions going forward on how to best help our patients. But the preliminary data here on decreased numbers of patients leaving against medical advice is huge. I probably don't have to talk to this crowd about that, of the converted, but there's a good body of literature that says patients that leave against medical advice are at higher risk of morbidity and mortality. So anytime we can prevent that is a win in my books. So the trend there I'm very happy with. Hopefully we see that going forward with our service. All right, so this is actually learning based on the consult itself rather than based on our deliberate educational sessions. So this is us surveying the referring team, so pharmacists, physicians, nurses, and 77.3% of people who had completed the survey were satisfied or very satisfied with the service and with the consult and recommendations that were provided. As you can see there, many noted that they learned something new and plan to apply it. Many also learned something new but weren't sure if they could apply it. I think that second point really speaks to probably more systems barriers. I'll talk about this in a couple slides' time, but not having a clear harm reduction policy in the hospital is probably one of those barriers. So we do have service user feedback from clinicians, and I want to make clear that that's where this feedback is coming from. Although we have feedback from service users, it was not enough to present yet. So we're still working on that, and I'll talk about that in a moment. But these were some comments specifically from clinicians that consulted our service. They want us to expand our hours and coverage. We need nights, weekends. We couldn't agree more. We are all on the same page there. And I do want to speak to this. There were some providers that noted that they were dissatisfied or neutral regarding the consult information they received or their experience with the service. And those respondents were less likely to think the response time was adequate, and they were less likely to say that they learned something from the consultation. So I think it's important to acknowledge this and learn what we can from this subset of the clinicians that are consulting us. We are certainly looking at our response times and what may or may not be affecting that, and looking at how we communicate with teams to see if we can bolster the experience of what they're actually learning from the consult, and so that we can be much more successful at capacity building. So I wanted to highlight some key accomplishments. So these are two members of our advisory council. This is Katie Upham and Dave Martell. And, you know, in-person, face-to-face meetings are something that we find very important. Of course, there is lots of virtual that we do, but that connection between it, whether it's advisory council members or team members, is really important to us, and we think is a big strength of this service. So some key accomplishments are that we're actively working on, and I hope you could join us earlier in the day, for Nova Scotia Health Harm Reduction Policy that we hope is being rolled out in a couple weeks' time, so that is no longer a barrier to whether consulting clinicians feel they can apply our advice or not. We've done a good job thus far engaging people with lived and living experience, specifically on our advisory council. And I'll talk about kind of areas for improvement in a moment, because it'll be on there as well. We're proud of our education session participation and the results of the surveys for those. Those are ongoing and forever being improved upon. We were instrumentally involved in implementing some changes to hydromorphone formulary so that we could start providing, with a bit more support, injection OAT, and we're working on a pre-printed order for that, and ongoing educational sessions, especially for nursing staff, around how to implement that, how to do somnolence scales, all the important parts of that. And our community connectivity is something that I think is an accomplishment, but also an area that we're working on. All of our clinicians on the team are incredible and have strong connections to community, as well as the members of our advisory council, which really helps us to further those connections in the community to help better serve our patients and make sure that they are being bridged to community resources as they need them. Some challenges and success factors, and this is of course in progress. One thing that stands out to me is that we are working on getting more patient feedback. One way that we're doing that is we're going to do focus groups, and of course we any patient that does give us feedback, we reimburse them for that. We do have surveys that we do give participants in this consult service. And, you know, we've had some challenges around getting large volumes of that feedback back, but continuing to do some problem solving and strength building around that. We continue to work on communication amongst the team, but also, more importantly, with patients and with their primary care teams. We would love to have more involvement from people with lived and living experience in the form of either peer support or active engagement in the educational sessions. There are some logistical barriers to that we're figuring out at the moment. We continue to, of course, engage leadership support, of which we have a significant amount of leadership support, and we are actively working on implementing the harm reduction policy. Now, That being said, these are practices that, of course, are standard of practice that are already happening on the consult service and in our institution, but having a harm reduction policy is really going to help our colleagues feel more comfortable actually implementing those recommendations on a day-to-day basis. All right. So next, we are in the midst of and are doing a full review of our service. Very importantly, the next task is sustainable funding, which has been secured, which is huge and very exciting for us. Thank you. We're going to complete the team-based review and the complete evaluation of our service and get a final report. Of course, the other things we want to do, especially with sustainable funding, is to expand our service as soon as we can. All right.
Thanks to Heather and Katie. And our original plan was to have some small group discussions at your table before coming back together as kind of a larger group for more questions. But since it's a small group, and for sure we're probably going to end up early, maybe we'll just kind of have a whole group discussion, but call it a small group discussion. So we do have these are some questions we were going to ask people to think about at their tables and discuss, and then kind of for a bit of time, and then come back and share their thoughts with a kind of broader group around, what were the key takeaways from them from their group discussions, and what did you learn most, or what was most important for you through this kind of presentation or discussion, and any other questions. But given this small group, maybe I'll just ask people to think about these questions and just open the floor to any comments, any feedback, any questions. We can go into more detail on some of the items if you're interested in that, or if you have some more clinical scenario questions, I'm sure Dr. Lyons can speak to those. I don't know if there's a floor microphone or... Hello? Oh, great, wonderful. I'll take that question. So the telephone service was actually on our to-do list for quite a long time, but we never seemed to get to it. And then over COVID, when things got very challenging, some of our few of our key kind of addiction medicine physicians' phones started blowing up, and they were just getting calls all the time. And they said, do something about it. We need to get this telephone consult service up and going. So over COVID, we stood up that telephone service quite rapidly. And it was at that time, and still is really, a Monday to Friday kind of 8 to 5-ish type of service. And it's open to any physician, any nurse practitioner or pharmacist in Nova Scotia, no matter where they're working. So it's not just hospital-based, it's community, anybody can call it. And so it was, people were kind of doing that on the side of their desks as, with a little extra compensation. And then when we started the inpatient addiction medicine consult service, we've kind of rolled it into there for now. Whether they'll live together forever, I don't know. So this, the inpatient IMCS, which is also a Monday to Friday kind of 8 to 5 service, it's the same team answering that call. Yeah, sorry if that was too long. Any other kind of questions?
Just before we go to the next question, this phone service has been really, really crucial in being able to disseminate knowledge or support to other sites while we're looking at how do we sustainably actually physically expand to other sites that are closest in our region. And like I said, we have the same challenge as most other provinces in being so spread out. So it's filled in a very necessary gap, and it's highly appreciated by clinicians who are calling in, so that's really nice.
Yeah, I will just add, we did evaluate that service, and it was very, very positive, the evaluation. It's not part of this evaluation.
Yeah, sure. Thanks. So I may have missed this. I came in a little bit late, but I was just curious about the size of the hospital that this was enacted at. And my other question is, I'm curious if you have any statistics on the reason for people leaving against medical advice, if you want to call it that.
Thanks for the question. I don't know if Katie or Heather can answer that one.
I don't have the statistics, but I think we all know that patients who present to emergency departments who are using substances are often stigmatized and undertreated or not treated appropriately. So when a client presents to the emergency department and they're not given kind of timely, effective, appropriate treatment, they're more likely to leave against medical advice. So that's something that our inpatient addiction medicine consult service is really striving to improve their substance use disorder care while in hospital. And this stigmatizing as well. I mean, ideally, all healthcare workers would leave their stigma at the door, but that doesn't always happen, unfortunately. And it's learning. Many people aren't even aware of their own stigmas. So that's all part of our teaching, and it's all part of the sessions that we have with inpatient teams, the education sessions. Our team talks about stigma and tolerance and things along those lines. Discomfort. We have to acknowledge that some teams, there's a discomfort in kind of administering high-dose intravenous hydromorphone because they see doses that they are not really used to seeing in their career. So they're uncomfortable, and they don't necessarily have experience with patients who have high tolerance to opioids. So that's also part of the education that we're providing to inpatient and emergency departments.
As far as the hospital that it's based out of, I'm going to guess on the number, but it is a tertiary care center. It's our largest hospital in Nova Scotia, and probably 500-bed hospital. I mean, not big for other centers, but certainly our biggest one, and where most of our patients are presenting. And certainly, even if they initially present in the community or in the periphery, if they're coming in with discitis or infective endocarditis or stroke or whatever the case may be, they're all ending up for that type of care at this particular center, which is great to be there, because all of them, if they need neurosurgery, if they need orthopedics, plastics, that's where they're going to end up. So it's great to be able to be in that center. And as far as people leaving against medical advice, certainly being in withdrawal and needing to attend to treating their own withdrawal because it's not being adequately treated in hospitals. Certainly clinically, probably the biggest concern that I see, as well as how they perceive they're being treated.
I'll just add, we don't collect the reason why people leave AMA. We do in some of our mental health and addictions settings, but not uniformly. However, we did pull some data as part of our business cases to try to get this funding initially for the formal service, and we did find in what we call the central zone hospitals, so more those urban center, Halifax, Dartmouth hospitals, that people presenting to our emergency departments with mental health and addictions concerns, I don't have the exact figures off the top of my head, but they were almost twice as likely to leave AMA from the emergency departments. So that's actually a good thing for us to maybe to revisit in a while to see if that changes.
I want to add to that as well. So another reason why clients may leave against medical advice is when they present to the emergency department, or if they're admitted with like endocarditis and other kind of substance use related conditions. Our harm reduction policy isn't quite there yet. It's coming down the line. We're expecting it to be, go through the approval process very, very soon. But clients who are used to, they want to inject themselves at the bedside. They want to kind of manage their own substance use disorder while they're in hospital, and failure to kind of meet them where they're at, they'll leave. Yeah.
Any other questions?
Recommendations that are just not applied because the team is not comfortable with it?
Yes. That's a straightforward answer to a very nuanced problem, which often it's not actually lack of education. Like, our teams on the units want to follow best practices and instructions. Lots of people love engaging with this population. And it's the question of, actually, am I protected and supported in actually following through with these recommendations? And that's where we're hoping that this gap is going to be closed really, really soon. But that is where the rub ends up being. It's not so much stigma, it's not so much ooh, am I going out on a limb here with my career to follow through on these recommendations, which is very unfortunate. And certainly people like our team has taken over things like distributing safer supplies and taken some of the harm reduction measures on ourselves to try to relieve some of that burden, at least in the interim, dispensing naloxone kits.
So you've been doing this for 2 years?
So service officially for 1 year.
1 year. So maybe it's too short, but I was wondering if with time, did you observe, or do you expect to observe not much of a reduction, but a change in the type of demand because of the transfer of connaissance?
Yeah.
Knowledge. Thank you.
Yeah, we are trying very, very hard to build comfort and capacity. And the truth is, the need is going up exponentially in our region at the same time. So the goal is to increase comfort and capacity, and I'm sure that will do that for cases that are not the most complex. And then we will be able to be more involved, more supportive, specific to the most complex cases that are, having behavioral concerns that we need to be more involved in or support the team more. So very hopeful that that's going to be the case, especially with some of the data from the learners from our educational sessions.
Yeah, and thanks for that. I'll just add a bit that we're not actually anticipating demand for the service to decrease anytime soon. Even if there is that knowledge a translation and increased capacity, because like everyone, there's a HHR shortage. We have a lot of travel nurses, a lot of staff turnover, a lot of kind of young nurses, and then we're working with physician learners. So, and we are a learning facility, and as well as other nearby hospitals are continuing to kind of reach out and looking for more support than just the telephone line. So we our next step soon is to be kind of exploring how we can incrementally expand, because we also have a limited number of addiction medicine physicians who are kind of ready and prepared to kind of start the service. So, we see the services growing and spreading over the next few years.
Yeah, and there's always this element of case finding as well. So the more well-known your service is, the more likely you're going to get all those consults that are probably missed and would have benefited from the service as well. Yeah.
Any other questions or comments? Or did anyone have any services in their areas that they wanted to share about?
Lynn, I was just going to add, sorry, that when a client is in hospital, if they don't receive timely, appropriate management of their substance use disorder, they often will exhibit behaviors, and if they were receiving timely, appropriate care, they would have better outcomes, and they wouldn't be exhibiting these behaviors like these that come from withdrawal.
Hi there. My name is Kim. I'm a registered nurse at Thunder Bay Regional. We met yesterday, and I am running an AMCS unit at Thunder Bay Regional Health Science Center. I'm the only one that's actually clinically seeing patients frontline so I'm very tired. And I've also learned a lot about triaging really quickly, but I've also not learned a lot about triaging really quickly. So I find I will come in on a Monday and it's like I have 11 consults to see, which isn't possible, right? Like you can't do it. So now you have to triage who you're going to see that day, who you're going to see that morning, who you're going to see that afternoon. Do you have a system that you find is somewhat effective? Because I'm trying, for a while I was trying to prioritize a merge because time is counted in minutes as opposed to days. But neurosurgery can be quite insistent that they are a priority, as can psychiatry, as can, right? Like, so how do you base your triaging, I guess is my question.
It's difficult.
It's really hard.
We do not have a formal way to do our triage. Our calls come in, and often our amazing nurse clinician is like the first point of contact. Because our team rotates every week, there's handover on Friday, so you have some idea of what you're coming into on Monday, as in, there were 3 consults we couldn't see, or there were none. So at least you know what's left over from the week before, and in those rounds, we do try to triage, okay, maybe try to see this person first, second, third, or this was the contingency plan for over the weekend. But there is no formal process, and I would say we do our best to go by acuity. We also do our best to see everybody, and that doesn't always happen, especially if you're one person. So doing our best with what we have. Now, we had that a lot more when it was an informal service, so all I can see is just how much better this is. So it's like very hopeful, but it's certainly not a perfect system yet, and we don't always have the capacity for the demand. It was 300 consults, and so break that down per week, and it's a little bit unpredictable, and that doesn't include the telephone consults that are coming in, so no formal process yet. I feel that.
And the service.
I believe there, Dr. Lyons, is there a little morning huddle where you do kind of officially, though, do try to
Yes.
Triage?
So on a day-to-day basis, after we've done the Friday handover rounds, Monday morning comes, the whole team gets together, and of course we game plan at that juncture and with. And increase capacity. 2 people. Yeah.
Yeah. I do. Just thinking about the process, et cetera, and, okay, where was I going with this? Oh, yeah. So you see people who are like admitted, and then you also see people who are in emerge. What about the folks that are waiting to get into emerge? Because that's, I would think, where a lot of people come and then they leave.
100% big problem.
And I know that that's probably, that would take more, you would need more people, or it would just be another, but I'm just curious if that was thought of and how that, if or how that's being looked at or addressed or thought about.
Certainly thought of. I will say informally, because all of the clinicians that work on the service also work in community when we're sending one of our patients in from community, where we've just Ubered them personally or sent them in an ambulance. We try to give the team a heads up, and whether that's to say, hello, we know you're here. I hope that in the future we can have more robust peer support that can do that, social worker, nurse, that we're all typically fairly familiar faces to this population. Like, it's not the biggest area in the world. But you make a really good point that left without being seen is huge, and huge morbidity and mortality.
I will just comment. I was happy to hear that there is kind of people with lived and living experience, peer support in some hospitals in kind of Ontario. And introducing peer support into this acute care inpatient setting is a first for us. And we did have funding from the get-go to have peer support, but and we do have peer support in some other areas within mental health and addictions, very specific programming. And it was a bit of a learning for us that it required really a special type of peer support person to be working within the acute care hospital and, supporting the level of acuity of the patients that are there. And so it took us a while to find a peer support worker who felt comfortable enough and supported to kind of stay over a bit of a longer term. And still, we don't know if that's if this individual will commit for a longer term, but she has committed until the end of kind of March. So, but that for us was a learning. And but yeah, if we do are able to kind of expand our peer support funding, it would be awesome to have somebody in the emerge. Any other questions, comments?
Lynn, I'll just add that the inpatient addiction medicine consult service plays a large role in the discharge planning as well. So our team does work in partnership with the inpatient teams to discharge, and make sure that they're kind of guided into the proper programs. And they also work very closely with other mental health and addictions departments like the opioid recovery program and the inpatient withdrawal management unit and things along those lines. So they do play a large role in discharge planning.
A little bit more than that. One of the advantages to having a fairly small center is that all the people that work on the inpatient addiction medicine consult service, we can draw on them to potentially have some of these patients in community if they're not already connected, which capacity is small, but sometimes that's necessary, and these clinicians are incredible, so it's very good.
The whole team isn't here, obviously, but I just do want to say kind of a kudos to the team. We've been pursuing funding, especially Dr. Tommy Brothers, who was a bit of a leader in the informal service for a few years and weren't really getting any traction. And then we were successful in receiving a SUOP grant from Health Canada, which, if any of you know, is very time limited, strict timelines. And so we had to stand up the service quite quickly and imperfectly. And eventually we got some additional funding from our provincial government, and now we have sustainable funding for the whole team. But, you know, the team of the physicians, the nurse, the social worker, we have a full-time secretary. We have someone who helps support us with the evaluation. You know, sometimes it's been challenging for them working in kind of a imperfect scenario when everything hasn't been you know, prepared and smoothed in advance for them, and then they've taken on some challenging situations. You know, part of their work is another thing that we had been working on was trying to promote the need for a harm reduction policy, and I think some of the provocation a little bit that had been happening as a result of the inpatient addiction consult service helped us get that over the line. And, you know, that policy and all its positive implications are going to be rolling out in a couple of weeks, and with lots of education and support to the team as well. So I just want to say thank you to the team for everything. Anything? Any other?
Thank you to those who stuck around in the audience. Thank you for listening to our presentation.
Thank you.
Thank you.